Good afternoon, everyone. My name is Garrett Schmidt. I am a managing editor for ACOExhibitHall.com, and I would like to welcome you to today's webinar entitled Remote Patient Monitoring Made Easy. All attendees have joined the webinar today in listen-only mode, and I would like to inform you all that this webinar is being recorded, and you will each have the opportunity to send questions, and we will answer as many as possible in the QA session at the end of the presentation. These questions are also being recorded, so even if we are unable to answer your question during the allotted time today, we will follow up to answer it via email after the webinar. So in today's webinar, our presenters will discuss 6 steps for success, which will combine information from well-known industry research, in addition to real-world examples and solutions. Our presenters today will be Chris Otto. He is Senior Vice President for Mobile Health Healthcare. Jareen Cordova, who is the Director of Telehealth Programs at Mobile Health Healthcare, and David Taylor, Registered Nurse, who is Implementation Consultant. And so at this time, what I would like to do is to now introduce Chris, who will begin our presentation with an overview of remote patient monitoring. Welcome, Chris.
Thank you, Garrett. My name is Chris Otto. As Garrett said, I run our healthcare division here at Mobile Health. And today's webinar is talking about remote patient monitoring, or RPM. And we're covering some topics that we believe are best practices on setting up an RPM program. Today's webinar is for the following people. If you are building a new RPM program from the ground up, or if you have an existing RPM program that you are looking to expand or make some changes in some way, or if you've tried remote patient monitoring in the past, excuse me, and it did not work out, then today's webinar is for you. The content for today's webinar comes from a white paper that we published here at Mobile Help. You can find that on our website. This white paper covers some of the topics that we'll be covering today, strategic as well as tactical strategies for implementing and running a remote patient monitoring program, and best practices to do so, pitfalls to avoid. So if you find today's webinar helpful, we hope that you will visit our website and download that white paper for more information. But first, a quick overview, and in broad strokes at a high level, here's what we're talking about, because telehealth and telemedicine can sometimes be ambiguous words. So today, when we're talking about telehealth, we're talking about specifically remote patient monitoring. And what we mean is we're talking about programs that are designed for patients that are in their own home or outside of a clinical setting, where they're using vitals monitoring devices to monitor their health information on a daily basis. And secondly, that health data and adherence data is collected for each patient and aggregated and presented in a way that clinicians can respond to that data by receiving alerts for patients that have abnormal readings or patients that are being non-compliant. And the value is that this allows clinicians to manage large populations by exception. For example, if with the case of congestive heart failure, for example, if you're using remote patient monitoring, the equipment in the home would be tracking weight as an example, and if patients experience a 3-pound weight gain in a 24-hour period, that may be cause for a clinician to intervene and adjust medications before that becomes more serious and requires a hospitalization. And the value of this exception management is that those patients that are compliant and are within normal readings can continue their daily activities and their daily lifestyle without any required intervention or even touch points by the clinicians. The value of a remote patient monitoring program is that it allows clinicians and providers to effectively manage populations outside of a clinical setting. So they may be at home, and that can be for a variety of disease states or patient populations. It can be used as a strategy for readmission avoidance, to keep people out of the hospital, avoiding penalties, for optimal management of chronic disease states. There's a number of articles that have been published citing very high outcomes for congestive heart failure and COPD. For example, with heart failure, it's been studied that the use of remote patient monitoring can reduce readmissions by as much as 50% on average for those patient populations. As you're looking at a program, it's natural to ask questions about the return on the investment. And while the details and the complexity of an ROI calculation is beyond the scope of today's webinar, in broad strokes, the value of remote patient monitoring is best realized in terms of cost savings and reduction in hospitalizations. So your savings for a program is typically the cost of the program offset by the reduction in hospitalizations, which is usually very expensive. So your average hospitalization can be over $13,000, sometimes as high as $15,000, depending on where you get your data. But these are expensive hospitalizations, and for relatively low cost, you can run a remote patient monitoring program that can keep those patients out of the hospital and save money. So that may be also from a perspective of penalty avoidance. So if you are currently part of a health system that is experiencing readmission penalties, this RPM is an effective strategy to reduce those penalties, or as value-based contracts increase, if you're a part of a health system or provider group that is sharing some financial risk and keeping those patients out of the hospital, then this is a direct savings that you can realize by utilizing remote patient monitoring. But beyond these hard cost savings, there are a number of soft value-added savings and value-added benefits to using remote patient monitoring, and it's important we don't lose sight of these as well. First and foremost, the quality of care provided and the patient satisfaction, the access to care, and the ability to retain patients over time, especially as we see the consumerism of healthcare grow. It's more and more important for health systems to differentiate themselves and ensure patient satisfaction and retain those patients for the long haul. And so remote patient monitoring can be effective in all of these areas. As a quick case study, in the United States, the VA is the largest utilizer of telehealth and remote patient monitoring, and they have published statistics that show that through the use of their programs, they have seen a reduction in bed utilization, 25% lower than when RPM is not used, a reduction in readmissions, but probably the most compelling statistic, in my opinion, is the 86% patient satisfaction scores that they have measured by patients enrolled in the program. So that's an opportunity to really keep patients at home, empower them to stay healthy, and that leads to higher patient satisfaction. So today's webinar is going to cover 6 best practices and pitfalls to avoid in setting up a remote patient monitoring program. And the next speakers will go through in detail on this. We've assembled this data based on best practices, working with other interviewing technology partners, service providers, and provider programs that have employed remote patient monitoring. And we've assembled what we think are best practices and strategies to avoid some of the common pitfalls, because despite some of the very compelling benefits and outcomes that make remote patient monitoring a valuable program to employ, there are a number of organizations that have struggled to get a program off the ground and running successfully. And so today's webinar is going to go into detail on those topics. So we have 6 topics: objectives and outcomes from a strategic perspective, how to set your plan correctly from the beginning. We'll cover technology considerations when setting up a program and how to integrate that into your existing care model. We'll also talk about patient enrollment and how an automatic patient enrollment can have big impacts on your ROI, as well as some understanding of the resources required, either in-house or outsourced, to effectively manage a remote patient monitoring program. And finally, we'll cover the importance of being able to tailor a program specific to specific patient populations or disease states. So our next speakers are experts in their areas in the field. David Taylor is a registered nurse and has run a telehealth program for Visiting Nurse Association of Rockford, Illinois, and is a consultant in telehealth and implementation for training and establishing new programs. And our own Jareen Cordova is our Director of Telehealth Programs, and Jareen's career has been in and around healthcare and telehealth programs, so she has extensive experience, and she runs our program here at Mobile Help Healthcare. So without further ado, I will turn it over to Jareen.
Thank you, Chris, and thank you for everyone for participating in today's webinar. This is a great topic. Talking about remote patient monitoring and including telehealth in your business plan in terms of providing clinical care is wonderful. The technology is amazing, and you can really broaden your reach with patient populations. Where we want to begin is focusing on those program objectives and outcomes. And if you think about this, what you're really doing is you're looking at your beginning goals, where do you want to start, the why behind your program, and then look forward down the path towards the outcomes that you want to derive and how you define success. So as you're looking at the why, what's motivating you to begin your program, consider whether or not your program is being established from the get-go to reduce risk, to reduce readmissions, to improve chronic disease management. It could be a combination of the three. It could be one or the other. But if you're able to solidify the why behind what you're doing, then you can determine which measures you're going to put into place so that you can benchmark along the way and determine whether or not you're meeting your outcome goals. Next slide. Oh, I'm sorry, go back one more. I apologize. So again, we were talking about getting to the outcomes and defining that success. So what does the success mean to you? And if you're looking to, say, reduce readmissions, what is the information that you'll have to gather in order to achieve that goal? When you're identifying patient populations, you may have to look towards some of your inclusion criteria as far as how many hospitalizations a patient has suffered, whether or not they meet the criteria of the chronic condition, and whether or not they're appropriate to be included in the program. And then you'll start to measure exactly what the reduction was by their participation in the program, what tools you need to put into place. That really encompasses developing your strategy overall. And when you're setting up a new program, you want to make sure and engage all your stakeholders. Some of the people that you'll have around your round table in terms of stakeholders will include people from your clinical team, but also you want to invite some of your IT counterparts, people from innovation or population health. If you have a home health organization, you might consider inviting in some of your sales or intake teams. That'll give them some preparation in advance kind of perspective of the goal of the remote patient monitoring program so that maybe you can layer it into your marketing strategy later on. Remote patient monitoring, as you embrace it and bring it into your clinical plan, this is a very brandable type of service. So it's something that can really distinguish you amongst your competition. Very, very thoughtful process when you begin planning this. I think that it'll set you up for success. So another group that you want to have in that stakeholder discussion is definitely leadership, because leadership is really going to define where you can start in terms of a size of a program and what kind of growth strategy they want to put in place so that you can scale and grow down the path. So as your team comes together and you've defined the why behind your program, you've kind of decided how you want to capture some of the outcomes, you want to look at a granular level at the type of technology you place in the hands of your patient. This is critical. The reason being is the basis and foundation of success in what we do with patients on any given day is really measured around their compliance, their participation or accountability within their care plan. So technology needs to fit and be adopted into their own self-management regimen. It was interesting because when working in the field, I came across a client who, this client had a small program. They had selected a certain type of technology. It was a tablet-based program, and the leadership team was certain that this was the right fit for their organization. However, when they placed the devices in the hands of the patients, the clinical team had a different experience. The clinical team uncovered that when patients came in with a flip phone, they found that they would not readily adopt to their tablet program. So it limited the growth of their program, it limited the inclusion of population in their program, and thereby reducing their ROI. A couple of years after they started their program, they still hadn't scaled beyond about 30 patients, I believe. So when you're choosing a technology partner, you want one that has a variety of different options. So as you look at this screen, you're looking at a couple of different gateways is what we could call them. And so these are the devices. The bottom white device is called a cellular base station, and the upper device is our tablet. Those two will interact with Bluetooth devices and pull in all the data needed from patients. The bottom one is very simplistic. However, it's still a high level of technology that connects that patient the way you need it to. But it's not threatening to patients who might be threatened by technology. However, what's unique about Mobile Help's tablet is that it's designed in a flexible way, flexible manner, easy to use. You can layer on the features so that patients can start out by just taking their readings, and then you can incorporate additional features and functions as that patient becomes more comfortable with the technology. You can add questionnaires, you can send content, you can send information, and engage in a video visit if needed. One other point I'll make on this slide is you see the wristband below the tablet, and you also see a pendant. As you're assessing patients to include them in your population, you may look to those patients who might be at risk of fall or other types of emergencies. You want to consider that frailty factor. And if that's the case, then you want a vendor partner who can add in features and functions that will fill the gaps that you'd otherwise miss. And in this case, we have that integrated PERS feature and the fall detection on board.
Good afternoon, everybody. This is David. I want to thank everybody again for joining us today. I wanted to talk a little bit more about the selecting of the technology for the patients that they want to use. You may notice a couple graphs or a couple statistics at the bottom. I'm going to get to those in a moment, as that kind of relates more to our step-down piece that goes along with the mobile health technology. But as Doreen was saying, you want to find the technology that the patient's going to become engaged with, something that they will be comfortable with, something that will maintain them and continue to help them grow and, as I like to say, be able to control their disease rather than their disease controlling them. Within the mobile health piece, it is very easy to use. It doesn't take up a lot of space. That's one of the other things with some of the other technology. There's a lot of cords, things that need to be connected. As Doreen had said, all of our peripheral devices are connected via Bluetooth. So again, with that, as far as like a weight scale, the patient may have the tablet base station or the cellular base station set up in their living room, which happens to have shag carpet. Well, as we know, that's not going to really work well for a scale. But with the Bluetooth technology, they can move that scale to another section in the house, 30 to 50 feet away, and maybe that would be a more firm surface that they can be able to take their weights on. Again, there is not a bunch of cords that need to be put together. So again, you don't need to have a very large area. It can be done on a bedside table or a coffee table. What we found with the program at the VNA, one of our pain points is that once we were discharging a patient from our services, we would end up having to take the equipment. Well, a lot of times people wanted to keep the equipment, so this was a system in which we could leave the equipment there with the individual, and they have a contractual basis with Mobile Help for that. Within that, within what we found after we left the equipment in, after they've been discharged, people still had an increased confidence in their ability to control their disease and their chronic condition. they came out to be a 47% increase in their confidence level. And then with the extra added of the PERS, people they felt as though they had an increase in their activity and their mobility. So there was an increased confidence level within that as well. So again, it's finding the technology that's going to work best for your patients, and then what's going to keep them engaged and keep them going and maintaining their conditions.
So in building upon what David just talked about and building upon our topics of identifying the how, identifying the why, and then building the stakeholder team around that, now we're going to move on to how do you create an extension of your care model? Well, you embrace RPM as part of the components that you offer. You don't necessarily need to approach it as adding a separate service line. You just want it to extend into the patient's home so that you have a full view of that patient's status 24/7 between clinical visits. That's what's critical. It's the time between clinical visits can be 3 months, and if a patient misses a visit, it's much longer than that. So during that time, we want to see what the patient's status is. And it's also a good period of time that you're focusing on helping that patient build better skills of self-management. So when you look at this circle on this graph, what we're looking at is when patients enroll into the program, that's their point of buy-in. That's when they're acknowledging that they're taking control of their health condition. And then we layer on training and education and using some of the tools that you have access to through this type of technology, not just knowing what their readings are, but actually reaching out to the patient through questions, through messaging, through video visit. And the patient's very engaged in that program. They're as much a part of it as you are, so you're a team. The patient also has access to their own patient portal at the same time, so they have the ability to pull down reports and share those with clinicians as they go out to have visits. It's a comprehensive chronic disease management program in that you have the ability to bill for some of those interactions that you have between clinical visits under the CCM codes. So managing these patient populations by exception also means that you expand your reach within those patient populations. You're taking some of the weight and burden off of your clinical team. Your clinical team's better able to manage the flow of patients, and those patients who come into the clinic are identified as those who need your attention, and that's done through the alerting system. So the alerts are going to notify you of a patient who needs your attention. You're able to either reinforce good behavior or divert bad behavior, provide coaching and information at the right time. So our end goal is not just to improve outcomes, but also to improve skills for the patient. And you do that in a very collaborative effort and with the right technology. One of the unique things that Mobile Health offers is that step-down monitoring. So in a traditional RPM program, what you do is you get a patient to a point where you can discharge them, you take the devices back and recycle that back into your population. We don't do that at Mobile Health. At Mobile Health, we actually offer the patients the ability to adopt their devices. If they want to continue to self-monitor, we want to maintain their continuity of care. And we want to see some of those numbers like David just spoke to, the 47% increase in confidence and an improvement in their ability to get out and feel more active. All of those things are very important, but they come from that continuity of care. Taking the patient off of an RPM program and discharging them to standard of care is not always in the best interest of the patient, so we can keep them on their devices and have access to their own patient portal. It all works well. So again, when you're thinking about how to use this as an extension of your current care model, what you do then is really focus on the patient population. What's your target goal? Do you want to start out with just maybe monitoring CHF and building a program so that you can grow from that and maybe layer on a second or a third disease condition? In that, you have to select a vendor group that's able to support you in that. Someone who can provide the consultative approach in listening to what your needs are and ensuring that they have the technology to support those needs. So you want a good ecosystem that's flexible to support you as you grow. You want them to be able to support you in different areas of growth. You may have a multi-location program and they have to be able to grow across the country with you. It could be a number of different approaches. So you want to know where you want to begin. Sometimes home health is the place you want to begin. It might be a CHF clinic. It might be endocrinology. Some organizations are adopting RPM into paramedic programs. The sky's the limit. RPM is very unique, and it's something that you build that fits your needs, but you want a partner that helps you with that. You also want to identify just the most simple things in terms of the chronic condition you're monitoring, but also the demographics within that population. What are the ages of the groups? What types of technology can they use? How do they like to communicate? Lots of questions, but as you define those before you launch a program, you'll find out that the program will roll smoothly. So as you approach each and every patient, once you've selected that population you want to start with, you drill down within that population to determine which of those patients are appropriate for remote patient monitoring, and the assumption is they're ready to go into that program. Some of them will opt out, and it's interesting because although you can do all the homework in the world at looking at the population in advance, until you really meet with that patient, you don't know which way it's going to go, and I'll warn you, don't go in with assumptions. I know I myself went in on an enrollment with a patient population, and we had one particular patient. He was a young man, the same age as my son, who had chronic conditions, multiple chronic conditions. And in trying to manage those chronic conditions, it was just he and his mom, and they only spoke Spanish. So they were very isolated, and I came in with the assumption that he'd probably not be very happy with the alert monitoring process and that we'd call him a lot. However, 2 weeks after he had been in program, he called his clinical team and thanked them for the connectivity, for the communication, and for feeling as though someone was invested in his care. My assumptions were wrong, and you never know. You never know who's going to adopt to it and be your rock star patient, but it's definitely worth doing the homework on drilling down on your patient population, identifying that patient population, and then engaging them in the accountability and responsibility in their own care.
And to give an example of the use of the technology and drilling down to a certain particular patient population, at the Visiting Nurses Association, where I am, we had an issue with our readmissions for CHF patients. And what we learned and what we found and felt was that it was the utilization of the equipment and the engagement of the people that were using the equipment. So what we did was we looked at just our patients with CHF and targeted them. What we did is we looked pre-admission as to if they had a primary diagnosis of CHF or if they had a secondary diagnosis of CHF. These individuals were given one of the monitors automatically. It took a lot of thought process out. It decreased the workload on our intake nurses of having to evaluate. We just made it a part of our program and part of our care. As you can see with the graph that shows in 2011, the red square, it shows 27%, which is what our readmission rate was for our CHF patients that year, which was above the national average. But what we noticed was that only 72% of our equipment was ever out with these individuals, and so we weren't getting those touches with those individuals. We weren't helping them take back control and getting the early recognition and early intervention to what might be going on, whether it be a weight gain or their blood pressure or something of that nature. So we implemented the program of making sure that the monitors were going out, and as you can see in 2012, we increased the utilization and we had a subsequent reduction in our readmission rates. And then we continued the program. Our utilization went up into the 90% range, and along with that, our correlating readmission rates dropped all the way down into 15% in 2015. So again, it's finding the right equipment, getting the buy-in, the engagement from the individuals, giving them the empowerment to take control of things. And again, like I said, we were able to get more touches with these individuals, and we're able to detect issues and move accordingly.
So I know we're running short on time, so I want to make sure and touch on a couple of other key points in your pre-planning process when setting up a remote patient monitoring program. One of the key things that you need to consider is a realistic outlook of the number of resources you need, which means look inward, look at your team, and make sure that you have the personnel in place to manage a type of program like this. It all starts with the program champion. In fact, I suggest that you also identify someone in place to be the program champion's assistant. And the reason being, there's a lot of flux and change in organizations, so you want to make sure you have a person in charge and then a backup. That's key. Also, you want to make sure you have a plan for monitoring alerts. You might do that internally and be a very high-touch program, which is great for patient engagement. However, if you don't have those resources, be ready to outsource. It's okay to outsource those resources. You can actually flip a switch and you can have a dedicated team who can manage the alert monitoring and only escalate calls to you at the point where they've identified patients need your attention. So that's definitely an option and something you can turn on and off. You can also add it on at the point you want to scale. Also address how you are going to manage inventory. Inventory is very important, so you need to know whether or not you need to outsource that kind of inventory management. So we pretty much covered just about everything you need in terms of planning a remote patient monitoring program. So you really just need to focus on those patient populations. You want to determine how much you want to grow, where you want to start, and be flexible. Understand that you're going to have checkpoints along the way. You'll assess your program for success. If you need to make changes, have a vendor partner there ready and who's going to be able to help you and be flexible with your needs. Thank you very much.
Okay, well, thank you, David and Jareen. I'm going to wrap up here on last slide. I just want to let you know that I do have a couple questions that are starting to come in, so I know we're a little bit long, but I am going to, for those of you that want to stay and listen to the questions and answer, or if you have a question, please use your GoToWebinar tool, and you should be able to ask questions and present those. And if we don't get through all the questions, then we'll certainly follow up by email and do that. So I hopefully from today's webinar, you gained some insights that might be helpful for wherever you are in the process of establishing a program or revamping an existing program. I just want to let you know that Mobile Help Healthcare, while we certainly are well known for our technology, we do have a full-featured remote patient monitoring platform, and actually Jareen mentioned earlier some of the different technology platforms that we have. All of those come with the option to integrate medical alarm seamlessly in that platform. The tablet, of course, supports video visits and patient education, but beyond the technology, and what may not be so obvious, is that we are full service in terms of consultation, training, and implementation. So if you have any questions on getting started, please don't hesitate to reach out, and we may be able to help you get started on a program. As mentioned in the webinar, we have the ability to outsource many of the logistics components, shipping, refurbishing equipment, sanitization of equipment. All those are core competencies that we hold here at Mobile Help, as well as the ability to monitor and triage patients remotely if that's something you don't want to do internally. So if you have any interest, please visit us at mobilehelp.com/healthcare. And now we will get to questions. So I think we have some questions here. The first one is, can you please go into more detail on the advantages of outsourcing versus internal clinical oversight? Clinicians are very busy. How do you suggest a new program start without breaking the current care model? Jareen, do you want to address that one?
Yeah, sure. When you choose to outsource any component of your program, and maybe the clinical call center is probably the first one people approach most, you really develop a plan with your vendor partner on selecting the vendor, the protocol, the contact center protocols, and you define those in your own terms, and they're white labeled. So it's to the extent that it's very seamless transition. Patients are being monitored by a call center, and they're able to monitor many more patients than any one FTE could, and for a much lower price point. So they're able to monitor for compliance. They can make calls out to the patient and check on them regarding their compliance, provide tier 1 troubleshooting, and they're also able to manage the alert process as well. And they don't provide any clinical intervention. That's the point where they escalate the call directly to your clinical team to offer support to that patient. So they'll put you in contact with the patients that you need to see.
That's perfect. Thank you, Jareen. And I'll just add to that that I know from experience with some other programs that we've launched that the tendency, especially if you're starting small, is to try to manage that, which is really a new skill set, and trying to manage those exceptions in-house without adding any new resources. And that, I can tell you from experience, that can be a recipe for disaster. So if you have existing case managers, or if you're doing this through a home health program, which it doesn't have to be, but a lot of programs are managed from home health. Trying to get home health nurses or case managers that are attempting to respond in real time to alerts in addition to their in-home visits is a complexity that can ruin a program before it starts. So I think outsourcing that, especially in the beginning, is a great way to start, and it's very you don't have to develop that skill set in-house. You can focus on your core business, and we can help you with the phone triage. Okay, next question it says for David. So in your experience, what is the #1 problem encountered in an organization implementing a new RPM program?
Well, what we found was pretty much having a champion that is going to run and oversee the program. You need to have somebody that's going to oversee the program, be in communication with the nurse case managers and the like. What you want to try and do with the RPM program is take much of the extra burden off of your field staff. So you have somebody who's seeing the alerts or who's getting the alerts from a call center, and then taking the next steps as far as contacting the patient, contacting the physician, and doing all the follow through. Whenever you have field staff that is then getting the calls from the call center or something like that, then they're having to take time out of their day, time out of their schedule. So I would say the biggest thing is to have that champion, or have those 2 champions that are going to make sure that things run seamlessly as far as any of the alerts that may be coming across from your patient population.
Okay, thank you, David. Thank you. Great questions. Next question. Can you please explain what step-down monitoring is? Yeah, so maybe I'll take this question. So one of the things that if you mobile help, well, I'll say mobile help is we have very extensive experience with direct consumer products and services. So one thing that's different about our programs is that we offer a product that comes with the support of a full-scale customer support team, technical support team, and we can really shine when it comes to helping that patient get the system up and rolling, and that's an advantage of the system. The step-down monitoring, as Jareen mentioned earlier, you have a patient that has learned to manage a disease state following some diagnosis or perhaps a recent hospitalization. They've entered a program and they've learned to manage their disease state with the tools and the technology that they were given. And then at some point when they're discharged from the program, it can be abrupt, as that patient has to return the equipment and go back to fending for themselves. And so while a lot of programs look at 30, 60 days out from hospitalization and a trend towards for 90 and 180 days, there's still the chance for readmission later. And so step-down monitoring allows that patient to keep the equipment on a private pay basis. It's very economical to do that because it includes a medical alarm device with that. And so that's what we're talking about with step monitoring. So all of our programs enable that patient to keep the system at discharge if they'd like to do so. Okay. Yeah, so yeah, we got a couple more. I think we have time for maybe one more. When starting a new program, what do you suggest as an optimum number of patients to begin with? Doreen or David, who would like to take that question?
I can start. David, you can fill in any gaps that I leave, but I think that assessing your patient population and drilling down to the disease conditions that you're going to monitor is where you start. And you may identify, say, 300 patients that you'd like to start with, and that's kind of a daunting number to some organizations, it depends. But when you actually drill down to those who are appropriate for RPM, it's usually about half of that. And then you reach out to that group, it might be another 50% that actually enroll in your program. So your starting point isn't going to be the total population you identify. It's going to be a little bit smaller. But to comfortably begin any given program, you want to start with a healthy enough population so that you have some ROI. If you start too small, if you start at 5 or 10, the amount of work involved and the selecting those patients is a challenge, and you want to make sure that maybe you start around 25 or 50 and you're going to be able to mark your outcomes better. You're going to be able to see your ROI and start to realize some success. You'll get some energy behind your program. Anything you want to add, David?
I was just going to say I agree with that. You probably want to start somewhere in the neighborhood of 20 to 30 patients to begin with. Again, a lot of it's going to depend upon what your experience has been with RPM. If you're a brand new startup, then I would say the 20 to 30 folks would be a good starting point, and then you can grow from there as far as disease state and what your census is as far as your organization goes. Now, if you've had experience with it already and you're looking to grow, then obviously you know what you can handle and where you're looking to go forward to. So, but like I said, yeah, definitely the brand new group, you don't want to start too big.
I would add too that if you're a national organization and you have many regional footprints, that you consider, one, the cultures of your different regions, but also the different goals within the different regions. So they may behave as individual programs even if you want to standardize across the nation. So your numbers may be quite large, but if you address them in smaller breakouts by region, you'll successfully achieve goals that way too.
Okay, great comments. Thank you very much. I think we're out of time, so I'm going to hand it back over to Garrett, who has some closing remarks.
Great. Well, thank you, Chris. I really appreciate it, and thank you to our other presenters, Jareen and David. And again, for those questions that we were not able to get to today, they will be answered via email. Also, if you have any specific questions for any of our presenters, their contact information is right here on the screen for you. So feel free to make note of that and contact them directly if you'd like to do so. And they'll be happy to, of course, follow up with you for further discussion. Also, on the bottom of the page, I want you to note that you will see the web page. And you will see that page updated in the next day or so with the recorded version of today's webinar, which will be available for viewing if you'd like to share that with anyone else in your organization or just refer to it again for yourself. It will also be available, by the way, for viewing on acoexhibithall.com in the reference library there. So I wanted to make you aware of that. With that, I would like to thank all of you for attending today. I hope you found it very informative and helpful as I did. And I hope you have a great rest of the day. Thanks for coming.